A quorum being present, the committee will come to order. Well, good morning, everybody. Good morning, Madam Secretary. Welcome. We're delighted that you're here. I believe this is your first appearance before the committee, and we certainly appreciate the opportunity to meet with you today. I realize your time is valuable, and we only have a small window to discuss a wide range of topics. And as we discussed earlier, it's likely that we will be interrupted by votes pretty quickly, so administrative comment for all of my colleagues. Mr. Miller and I and the Secretary are going to all try to get our opening statements done, and at least Mr. Miller and I, depending upon how quickly they call votes. By any definition, the Department of Health and Human Services is a massive federal agency. It employs nearly 76,000 workers and maintains an annual operating budget in excess of $800 billion, the largest of any agency in the federal government. While a great deal of the Department's resources are directed to Medicare and Medicaid, more than $100 billion in taxpayer money is spent on various social service programs. Many of these programs fall within the jurisdiction of this committee, such as welfare, the Community Services Block Grant, and provisions of the Child Abuse Prevention and Treatment Act. No doubt these programs are well intended. They reflect our nation's ongoing commitment to serving those in need. In recent years, however, the federal budget has been placed on an unsustainable path taxpayers can no longer afford. This growth has forced us to take a hard look at every facet of the federal government as we consider how to rein in spending. I realize the administration has offered some modest proposals for scaling back the cost of your department, Madam Secretary. However, these proposals fail to rise to the challenges we face. If we adopt the President's plan, the Congressional Budget Office reports the federal government will spend $46.2 trillion, impose $1.5 trillion in new taxes, and add roughly $9 trillion to the national debt over the next decade. This is unacceptable. In health care, the news is just as disappointing. It has been a little more than a year since the President signed his health care bill into law, yet already the price tag for the new law has increased by more than 50%. A plan that supporters promised would reduce costs will instead charge taxpayers more than $2.6 trillion when fully implemented and add more than $700 billion to the deficit. Our national conversation has become so consumed by trillions and billions that it's almost impossible to comprehend the magnitude of the crisis we face. These reckless policies affect not only the nation's bottom line, they undermine confidence in our economy and harm job creators' ability to expand businesses or hire new workers. The current fiscal crisis demands we examine every program to ensure every taxpayer dollar is spent efficiently and effectively. Every federal agency must be part of that effort. If we fail to promote responsible reforms and make tough choices, our nation will no longer be able to provide assistance to those who need it most. Those who argue for a timid response threaten the very safety net many Americans rely upon. We know many of the decisions we must make will be unpopular. Writing about the spending cuts in the final appropriations bill, the President's communications director noted, quote, "Many will be painful and are to programs that we support, but the fiscal situation is such that we have to act." Close quote, and I couldn't agree more. The nation faces an historic moment. We can continue the status quo of more spending, more taxes, and more debt that will ultimately lead to our nation's decline, or we can make the tough yet necessary choices to preserve the promise of our country and the prosperity of our children. That's the course a majority of this House has supported, and one that I believe an overwhelming majority of the American people expect us to take. At this time, I'd like to recognize Mr. Miller, the senior Democratic member of the committee, for his opening remarks.
Thank you, Mr. Chairman, and thank you for having this hearing. I want to join you in welcoming Secretary Sebelius to the committee. From educating our youngest children in Head Start to ensuring seniors access to health care and Medicare, your department administers programs that have unquestionably made our families and communities healthier and our country stronger. In recent months, we've seen an unprecedented attack on these programs that help millions of American families. While we must address our nation's long-term deficits, the budget priorities pursued by the Republican majority have put much of the sacrifice directly on the backs of children and seniors. Cutting 130,000 children from Head Start isn't about rebuilding our economy. The repealing of historic health care reform law won't help families and businesses get costs under control. You and your agency, Madam Secretary, have primary responsibility for implementation of the Affordable Care Act. A year after its enactment, the reform bill is still doing the right thing. It is the right thing to do to help families struggling with affordable coverage. It is the right thing to do for businesses crushed by skyrocketing premiums over the last decade, and it was the right thing to do to finally end the worst abuses of the insurance industries. The Affordable Care Act also makes significant strides in combating fraud and abuse in the Medicare and Medicaid system. and it includes key healthcare cost controllers identified by top experts as critical to getting costs under control without rationing care. And this is part of keeping the bargain and the promise that this country made to our nation's seniors. And it's a promise and a bargain that this nation must keep to our seniors. However, the same cannot be said about the Republicans' budget. They achieved savings not by making Medicare work better, but by shifting costs onto seniors. In fact, under a report we released this morning, seniors would have to shoulder approximately $6,400 more in health care costs in 2022. The typical 65-year-old in 2022 will spend half of their Social Security on health insurance premiums under the Republican budget plan, and that cost increases with each passing year. Using the CBO numbers, the Center on Economic Policy Research has found that to buy Medicare equivalent policy under the Republican plan, the median 85-year-old in 2050 would have to spend twice their annual income. In this committee, we should be concerned about what this means for workers today. Based upon further analysis by the Center, which I submit for the record, the 54-year-old today would have to save an additional $182,000 over the next 11 years just to pay for the increased health care cost under the Republican budget. This is over and above what they're already putting away every month in their savings, in their 401ks, in their retirement plans. So these workers will have to find around an extra $1,000 to $1,300 a month to put in their IRAs or their 401k plans. And that is contingent upon the market not crashing right before they retire. This committee has been concerned for years about the sufficiency of workers' retirement plans. In 2007, before the recent crises, the Census Bureau found that half of all the workers had no retirement savings. In 2010, the Employee Benefits Research Institute found that the average retirement savings shortfall was over $47,000 per individual, and all of that was counting on Medicare. So how do these workers find another $182,000, especially since for middle-class workers in this country, wages have essentially been stagnant since the 1970s, and labor protections for workers who try to organize and do it better for their on the job for their families and for their communities, those ability to organize are now under attack. Under the Republican plans, seniors will go into debt, and they will be forced to sell their homes. They've spent a lifetime paying off, and they'll have to rely on their children just to pay basic medical care. This is not what anyone envisioned as a dignified retirement. This was not the bargain. This was not the promise that this nation made with its seniors. And that clearly understanding the need for additional reforms to make sure that Medicare is sustainable for seniors in the future and sustainable for taxpayers. I'm very encouraged to see that as the Republican negotiators go to the White House today, they're reconsidering the idea that they would split Medicare, that they would put the 65-year-old in the jeopardy that I had outlined under the economic policy study, and they would put this burden on the savings of middle-class Americans today. And they also have the ability, as they go to the White House, to think about whether or not Medicare is going to be included in the discussions around the debt limit. It sounds like they're reconsidering that. I hope they are. They can also understand that they can build on the a little over $700 billion that they've adopted in Medicare savings for their budget that are in the Accountable Care Act. And so hopefully we can continue to build on those kinds of savings that come from bending the cost curve for health care for seniors in this country and for the cost of the Medicare program. Again, I welcome you to the committee and thank you so much for your service to our country.
I thank the gentleman. Pursuant to Committee Rule 7C, all committee members will be permitted to submit written statements to be included in the permanent hearing record. And without objection, the hearing record will remain open for 14 days to allow statements, questions for the record, and other extraneous material referenced during the hearing to be submitted in the official hearing record. Again, before I introduce our distinguished witness, I want to make an administrative announcement. The Secretary has a hard stop time at 12:30. I want to encourage my colleagues when we get into questions and answers that you try to abide by the 5-minute clock so that everybody has a chance. And again, we expect to be called to votes momentarily. So let me move to the introduction. The Honorable Kathleen Sebelius was sworn in as the 21st Secretary of the Department of Health and Human Services on April 28, 2009. I got the wave down here. Everybody knows who the Secretary is. So in the interest of time, Madam Secretary, you're recognized.
Chairman Kline and Ranking Member Miller, members of the committee, thank you for inviting me here to discuss the President's 2012 budget for HHS. The President's budget ensures Americans live within our means. As the lead up to the budget, we looked at all of our programs, cut waste, eliminated programs that weren't working well enough, redesigned our programs to put a new focus on result. And in some cases, we cut programs we would have kept in place in better fiscal times. At the same time, our budget protects the investments we need to keep Americans prosperous in the years to come. From investments in Head Start, so our kids can compete with those in any nation, to investments in biomedical research that allows the U.S. to continue to lead the world in discoveries of breakthrough cures and treatments. Today, I want to focus my oral testimony on some of the provisions in our budget that will benefit the youngest and the oldest Americans. But first, a quick update on the implementation of the Affordable Care Act. Thanks to the steps we've taken so far, children can no longer be denied coverage because of their pre-existing health conditions. Families have new protections with the Patient's Bill of Rights. Businesses are getting some initial relief from the soaring health care costs, and seniors have better access to prescription drugs and preventive care. Tomorrow, we'll announce that more than 18,000 Americans who've been shut out of the insurance market are now taking advantage of the pre-existing insurance plans in their states. Some states are still reporting figures, so those numbers could go higher, but that's about a 50% increase in the last couple of months as people begin to learn about the program. It's encouraging to see that more people who need health insurance are getting it. But we know that's not enough, and that's why we're continuing to work with states and national advocates to reach eligible people and let them know coverage is available. We're also working with insurers that have chosen to notify people about the pre-existing insurance plan when their applications are denied. And we're evaluating ways to reduce premiums and ease eligibility standards to expand access to the plans. For many, these plans provide access to life-saving treatments, so it's vital we continue to find those who are eligible and get them enrolled. Our budget builds on the momentum of the Affordable Care Act with critical investments to provide for and protect our most vulnerable citizens. We know there's nothing more important to our future than the healthy development of all of our children. Science continues to show that success in school is significantly enhanced by higher quality early learning opportunities. Earlier this year, we got the results of a latest study to look at the value of early education. Researchers followed children from low-income families enrolled in Chicago early education programs until they turned 26, and found that over that child's lifetime, the program generated as much as $11 in economic benefits for every dollar spent. Now, that's a huge payoff. So even in tight budget times, our budget makes room for new investments in child care and Head Start, which have a long history of bipartisan support. But the budget does more than provide additional resources. It aims to raise the bar on quality in child care and early education by supporting key reforms to transform the nation's early childhood system into one that fosters healthy development and gets children ready for school. Quality child care is more than just providing babysitting. It supports healthy child development and school readiness, and that's why our budget puts forward principles for legislation reauthorizing the main child care program, the Child Care and Development Block Grant. These include promoting better health and safety standards, putting more information about the quality of different child care options into parents' hands, and improving workforce training to make sure that the people caring for our kids have the skills they need. We look forward to working with this committee, Mr. Chairman, as you consider these issues. We're also promoting better quality in Head Start, using new evidence-based evaluations in classrooms, including a tool that will help Head Start programs see what's working and improve what isn't. In addition, we've revamped the training we provide to Head Start directors and teachers to make sure best practices actually reach the classroom. And we're proposing new rules to require the lowest performing programs, the bottom 25%, to compete for funding. By giving programs incentives to raise the quality of their services and removing the weaker programs, we want to ensure that the best programs are the ones serving our children. Finally, we're pleased that the FY 2011 budget included funding to allow states to fund innovation in early education. And our 2012 request includes $350 million to continue this key investment. Taken together, these initiatives are designed to create an early learning system that gets every child ready for school, supports healthy child development, and features high standards, whether the child is in a pre-K program, a Head Start center, a child care center, or a family daycare home. They'll help ensure that American children start school as prepared as any in the world. Our budget also focuses on creating safe environments for children and families. We thank the committee for reauthorizing the Child Abuse Prevention and Treatment Act and the Family Violence Prevention and Services Act last year. And our budget includes more than $200 million for the child abuse and domestic violence programs authorized by these laws. The budget also provides critical support for seniors. It invests in the care and services seniors need to stay active and engaged in their communities. And it addresses the terrible problem of elder abuse and provides funding for caregiver services that gives families the peace of mind and enable them to continue to care for their relatives. These goals guide our department's work on the reauthorization of the Older Americans Act coming up later this year. For more than 45 years, the Older Americans Act has enjoyed broad bipartisan support. In the past year alone, the law's comprehensive home and community-based system has supported nearly 11 million seniors and their family caregivers. But the need for this kind of support continues to grow rapidly. Every day, more than 9,000 baby boomers turn 65. That's nearly 3.3 million a year, many of whom will be ultimately cared for by their family members. We need to do all we can to help families caring for their loved ones, and the Older Americans Act gives us the tools to do just that. We look forward to working with this committee to reauthorize the Older Americans Act and build upon the law's long record of success in serving our families and our communities. The 2012 budget makes tough choices and smart target investments today so we can have a healthy, stronger, and more competitive America tomorrow. That's what it takes to win the future, and that's what we're determined to do. Thank you, Mr. Chairman, and I look forward to our discussion.
Thank you, Madam Secretary. We're getting updates on votes every few minutes. It looks like the latest guess is around 10:30, so we will start with questions and go until we get called to vote. I know there are going to be a lot of questions about health care, and I'm tempted to jump in and start asking those, but I want to go in a little bit different direction, Madam Secretary. The most recent Head Start impact study says that, quote, the advantages children gained during their Head Start and age 4 years yielded only a few statistically significant differences in outcomes at the end of first grade for the sample as a whole, close quote. Can you expand that at all? Have you been looking into that? And then, as a follow-on, I'll just get them both out there. Again, the latest Head Start impact study states that, quote, there was no strong evidence of impact on children's language, literacy, or math measures at the end of kindergarten or at the end of the first grade. Can you tell us what you're doing to get at that? It's a vexing problem we've been looking at for a long time.
Well, Mr. Chairman, I think that we certainly share the goal of making sure that both the child development and the early learning skills are focused on in all of our child care and early education program, and Head Start is key among them. Early Head Start and Head Start continue to show improvements in child development and in learning skills, but how long they last into the school life continues to be determined. So we're continuing to take that information very seriously, as I said in my opening statement, to revamp both the teacher training, to upgrade the quality standards, to make sure that we are analyzing the curriculum, the core curriculum in child care, but I think studies continue to show that early learning programs do make a significant difference in 3-year-olds who spend a year in Head Start have a significantly different impact when they go into grade school than those who don't. What we need to do is continue that progress once they hit school.
Let me follow up just a little bit. I think that probably everybody on this committee has observed and would agree that that early learning is helpful. But my question is specifically talking about Head Start, where the quote was, there was no strong evidence of impact on children's language, literacy, or math measures at the end of kindergarten or at the end of the first grade. So those efforts that you're undertaking, I hope are focused and will prove to be fruitful in Head Start, because I think we've been disappointed many times that the Head Start program is not really helping that many kids be ready for.
Well, I would say, Mr. Chairman, we have an unprecedented effort underway right now with the Department of Education, where we are working very closely with them to kind of align standards to make sure that the early childhood programs run by the education system have the developmental aspects that I think have been a component of Head Start, and that the Head Start programs have the curriculum-based component that often we're more focused on in the education programs. We think that regardless of where a parent chooses as an appropriate out-of-home placement for their child, whether it's child care or Head Start or early Head Start or a public pre-K program, we should have the same goals and the same alignment of initiatives. So we are taking those issues very seriously. We think school readiness has to be an important component of Head Start, and we continue to upgrade the programs. We're also recompeting programs that have the lowest 25% of the impact on children. We think that's an important aspect to make sure that we continue to drive improvements and not just continue to fund programs because they've historically had funding.
Thank you. I'm going to move to another subject quickly. Your agency administers the Early Retiree Reinsurance Program, which provides money to employment-related retiree benefit plans. An HHS report dated March 31st, 2011 said the program, which was supposed to last until 2014, had already spent $1.8 billion and is not accepting new applications as of the end of April. This is troubling on a number of levels. I'd like to know if it's true that one plan sponsor, the United Auto Workers Retiree Medical Benefits Trust, received $207 million, or 11.5% of the total amount paid by the program. And during the plan approval process, did this plan have to demonstrate or prove that it needed taxpayer funding to pay claims or maintain solvency? I have a number of other questions relating to this, but I think you see the point. We're concerned how this is, the decisions are made or how this money is awarded. Can you address that specific?
I'd be glad to, Mr. Chairman. I can't answer with specificity about the UAW plan. I'll be glad to give you the written answer to that.
Would you please?
I just don't have those facts off the top of my head. But this program has been enormously both popular and helpful, I think, to those companies and programs who wanted to continue their early retiree coverage. We've seen employers consistently dropping that coverage over a period of time, and in fact, one of the largest growing groups of uninsured in America were the 55 to 65 years old who retired early, and they and their spouses often lost that employer-based coverage when those plans got too expensive. This program was widely advertised, announced. There was a process where applications were accepted universally. They had to present documentation to our office. It wasn't our office picking and choosing who got in. Programs qualified if they met the statutory qualifications. And the way this works, Mr. Chairman, is individual claims are presented that rise above the threshold. So it's a stop-loss policy, if you will, for early retiree programs. The most expensive claims are presented and they are paid. We share 80% of those costs. So we give employers some ability to predict their costs going forward, and that has actually stabilized the early retiree plan. So plans are not being paid from a presumptive pipeline. We are actually paying after the fact as claims are being presented, and we'd be happy, again, to share the documentation of how that's working. It's okay. Paid at 6 months after the claim is made. They come in and the money goes out the door.
Okay, I'll present some questions for the
Sure.
record.
Be glad
for example, it looks like we're going to run out of money, and if you requested that money in the President's budget and so forth, I'll present those for the record and then
Would be glad to answer that.
recognize Mr. Miller for.
Thank you very much. Just on the chairman's earlier discussion on Head Start, I don't know the study he's referring to, but I know on previous studies, the question that had to be asked was, what was the quality of the program the child was entering into in kindergarten or first grade? We know that many of these children in unfortunately, the poor performing schools, the poorer schools in our country, they can lose a whole year over the summer. And so the idea that, it's what do you follow on with after Head Start that has determined. But I'd be glad to look at the studies, but I know in the past that's been a significant impact on what happens to children afterwards. I want to turn to part of the Affordable Care Act that I had a chance to participate in my district last month, and that was the Partnership for Patients Initiative, which is really about, as I witnessed this, is this is an effort to try to reduce medical errors, to improve care, to stop the accidents that take place, improve the sanitary nature of a hospital, from washing your hands to a whole range of things that were popularized, I think, to some extent by Gawande and making of the list before surgery and what you should be thinking about when you're doing that. I was quite surprised at the range of support for this program from the Chamber of Commerce, the Business Roundtable. After the event, the profits and nonprofits and public facilities all wanted to say, how do we get to participate in this? And in the San Francisco Bay Area, it's quite an array of hospitals, from the most successful nonprofits to a Kaiser system of a prepaid nature, and then to public facilities. My understanding is that there's about 98,000 people who die in the care of hospitals or shortly thereafter as a result of errors and mistakes that are made. And that in the facility that we visited, question of hand washing all of the time as you move from room to room, from facility to facility. They had a simple plan of putting bright red tape behind the head of the bed so that those who are on respiratory assistance are the beds kept at 30 degrees. Dramatic reduction in pneumonias in that facility. People who are susceptible to slips and falls now have to wear very bright red socks and slippers, so that people are aware of that. Slips and falls have gone down about 50%. It's just ricocheting through the system in terms of the improvement in the outcomes in that facility. I think your agency has said that we look for savings down the road of about $50 billion under this initiative. But it's very clear from people who are paying the bill, the employers and others who are participating in this, that there's a pretty big bet being placed on improving these outcomes. There was a piece in the Wall Street Journal last week that even with all of the admonishment, as medical staff moves from space to space, there's over a vast majority of them are still not washing their hands. Those of us who have visited the veterans at the veterans facility know every time you move between one space to another, whether you've touched anything, you have to go through the sanitizing of your hands as you move around that facility. And I just like your comments on this, because this seems to me, given the people who are rushing forward to say we haven't yet been able to participate, who want to participate in this program.
Well, Congressman Miller, we've had enormous enthusiasm and excitement, as you have indicated, across the range of not only healthcare providers, but employers, business groups, patient advocates. We do have about 100,000 deaths a year, but hundreds and hundreds of thousands of people are injured. And in fact, the most recent study said that 1 out of every 3 Americans who goes into a hospital is injured by care that they receive in the hospital. That's a very large number, and it not only causes enormous injury and deaths, but it costs an enormous amount of money that we shouldn't be spending. In the past, Medicare has been a volume purchaser. So whether the hospital had a 60% infection rate or a 0% infection rate, you basically got paid the same way. The Affordable Care Act gives us a framework to actually begin to head in a very different direction, to use the enormous payment system of Medicare and Medicaid to be a cost driver to encourage value instead of volume, and we are taking that very seriously. So the Partnership for Patients has two very aggressive goals: reduce hospital-based infections by 40% over the next 3 years. The ultimate goal is 0. We shouldn't be hurting people when they go to the hospital. That has to be our goal. And reducing unnecessary hospital readmissions by 20% over the next 3 years. And those goals are achievable because there are pockets of that care going on right now in the country. So we're going to be providing technical assistance, sharing best practices, helping to encourage. But as you say, we currently have over 1,000 hospitals who have signed up. We have employer groups, we have patient advocate groups, a range of partners. And frankly, the private sector is enormously enthusiastic. They have been trying to do this for years, but they don't have enough juice in the system. They can't touch every hospital with their purchases. So joining together on quality outcomes not only improves care for Americans, but dramatically lowers cost. And it, we have two ways to lower the rising costs in Medicare. It's improving care and getting a better bang for our buck and lowering costs that way, or just cutting off benefits. And I think the Partnership for Patients gives us a real pathway to a new kind of delivery system change.
Thank you. Thank you, Mr. Chairman.
I thank the gentleman. Dr. Fox, you're recognized.
Thank you, Mr. Chairman, and thank you, Secretary Sebelius, for being with us. I was interested in hearing what Mr. Miller was saying and talking about all these wonderful things that have happened over using common sense. What's astonishing to me is that it's taken so long for the department to be able to put in common sense issues like this. It seems the federal government doesn't often care about cost until our backs are against the wall, and we ought to be caring about cost every day in every program. There should be accountability in every program every day, and it's disappointing to someone like me who cherishes common sense that it's taken so long to get to this point. But let me get to my question now. I find it really interesting, Madam Secretary, that you and the President said over and over and over and over again that if you like it, you can keep it. You promised the American people that if they had health insurance, that they could keep what they had. But we now know that although you promised people to be able to be grandfathered in, the regulation that you published last year found that 69% of employers and 80% of small employers will lose their grandfather status by 2014. So what you said wasn't true because you have established regulations that were not in the law to guarantee that people can't keep their health insurance. So how do you reconcile what you promised with what you've put into effect and the fact that this is going to cost so much more money as a result of it?
Well, Congresswoman, I first of all share your concern that common sense doesn't always drive policy. The error report came out 10 years ago indicating we had a serious safety problem, and frankly, no one paid a lot of attention to it in the Medicare agency, and I'm pleased that finally the Affordable Care Act presented the platform to allow us to have the kind of regulation in place that moves in a brand new direction. In terms of the insurance market, as you know, employer participation in the market is voluntary, and small business owners and particularly individuals move in and out on a regular basis. And you're absolutely right, the law doesn't mandate that employers who had a policy in place in 2010 when the bill was signed must keep that policy in place. That is not part of the law, so they still have free will and free choice. What we did do is create a platform that said, basically, if you keep essentially the same kind of benefit package, if you don't shift a huge amount of costs onto your employees, if you don't dramatically cut the kind of benefits that your employees now are able to access, then you are grandfathered in under the plan. And so it's really an employer choice whether or not the grandfather status is going to meet them on into the future or not, and that's really the way the private market works. The employers come in voluntarily. They may or may not provide coverage. We're seeing actually, I think, some good news where small employers are beginning to re-enter the market for the first time in a very long time. We were on a trajectory where if you work for a small company, and I certainly saw this as an insurance commissioner in Kansas, and I heard about it over and over again when I was governor of Kansas, that the most vulnerable people in the marketplace were folks buying individual coverage and folks, farm families and small mom and pop shops who were in the small group market, and that market is beginning to stabilize, and I think that's very good news.
But, Madam Speaker, Madam Secretary, why don't you just leave free choice out there, period? It'd be up to the employers to decide what they can afford to do, and it would be up to the employees to decide whether they want to go on the private market themselves. Why not allow that free choice? You all on your side of the aisle have very limited issues on free choice.
Well, I think, again, the platform of the Affordable Care Act, Congresswoman, is that employers, particularly in the small market, have to look forward to a new, competitive, lower-cost marketplace, according to the Congressional Budget Office. They will have choices, and the cost for those premiums will go down. They currently have very limited choices in the marketplace and often pay 18% to 20% more than their large competitors just because of the size of their company. So they'll be in a large pool, they'll have some choices. Individuals also will be able to purchase coverage and have some assistance purchasing that coverage if they're lower wage workers, if they don't have access to employee coverage. So we have a market that will be framed by states around the country that doesn't exist right now and gives a lot more choice and a lot of cost relief to the most vulnerable folks in the marketplace.
Thank you. Mr. Kildee.
Thank you very much. Madam Secretary, Head Start, when it was first authorized in 1965, placed the program in HHS rather than the Department of Education because it was more comprehensive than just education, to include health and other social skills, among others. I was chief sponsor of the 2007 reauthorization of Head Start, and we tried to enhance those purposes that we first put in 1965. How has the fiscal year 12 budget help you in your efforts to bring these programs, integrate them together, the various purposes beyond the purpose of education in the Head Start program?
Well, Congressman, I think that the President certainly shares your belief that Head Start is a very important component of an early childhood framework for America, and that's why he has proposed an increase in Head Start funding as we move forward and the ability to serve additional children. I think also the notion that we are have a very exciting opportunity with the passage of the 2011 framework, the Early Learning Challenge Fund, which will be housed in the Department of Education but participated in by HHS and Education, which actually is a kind of mirror of race to the top for early childhood education, driving quality initiatives, aligning the kind of standards, and giving states the opportunity to really innovate in early childhood education. And what we're seeing around the country is that Head Start is no longer operating in a silo, but the many governors have put together broad-based early education cabinets where the Head Start folks are very much at the table with the early childhood education folks, with the child care folks, which was almost unprecedented. And I know I did that again when I was in Kansas, but that's a mirror of what's happening. And I think the integration of developmental skills, One of the features of Head Start that I think is very critical that, again, needs to be incorporated into a lot of early childhood programs is involvement of parents. There is a significant parental aspect to Head Start where they participate in a child's education at the earliest point, and hopefully that continues on. So there are a number of components which not only look at school readiness, but look at the whole developmental readiness of a child that we are trying to improve and actually share with our partners in the education system.
Thank you very much, and I encourage you to encourage the governors and those in the states to continue to do that. Thank you very much.
Gentleman yields back. I'm going to recognize Dr. Rowe in about 3 seconds, and for everybody's information, his will be the last question as we head for the floor to vote, just alerting all the members of the committee. Dr. Rowe, you're recognized.
Thank you, Madam Secretary, for being here today, and to let you know that my background is a physician practicing in Tennessee, where we had an experiment with an expansion of our Medicaid program, and the first question I have is how many people will the Affordable Care Act cover? Do you estimate right now that it will cover?
How many new people?
New people, yes.
The estimates are in the 30 to 35 million range.
And it looks like that most of this expansion of coverage is just an expansion of Medicaid.
Doctor, the data that I have seen, it's estimated this is about half and half. About half will be exchange eligible and about half will be Medicaid eligible. So about 15 million are likely to be Medicaid eligible.
Well, what CMS says is that 24.7 million will be added, an increase of 5 million. These are Medicaid, and this is not me, this is CMS. And CBO estimates 8 million more than we thought. Do you agree with those numbers, what CMS said or what the CBO said about their estimates?
Again, the numbers that I'm familiar with are about half and half. So I'm not sure quite what you're looking at or quoting.
Well, I'll send some, I'd like...
It may be who's uninsured, and there are a portion of uninsured that aren't assumed to be fully insured. I mean, I don't know, but...
Well, I'll get those in written form, too.
Okay, thank you.
I'll definitely... Do you think this bill is simple, or is it complex to understand? And have you read the whole bill?
I have read the bill. I think it's very comprehensive because it deals with all aspects of the healthcare system.
Well, let me get down to just some practical aspects of it. I have a practice that has about 350 employees, 80 primary care doctors, and we insure about 300 of them. I mean, everybody's eligible. And we've done that for 40 years in our practice. Very proudly have provided health insurance coverage, retirement, and so forth. Right now, we pay about $5,500 per employee, or somewhere, it may be up to $6,000 now. I haven't seen the numbers for this year. If someone goes to the exchange and we decide to pay the $2,000 penalty, we save ourselves in our practice $1 million. That's one little business. Another business in Tennessee that I've seen and talked to those folks, because we don't know what, I know someone, this is another question I'm going to have, is who defines what an affordable care is, and what is that, and what's in the package. This company will spend, they think, $40 million more in their business complying with these new regulations, or they can save $40 million by having those folks get their health insurance through the exchange. Now, we had a very good presentation, and you probably should read this, from the Lockton Group. Mr. Brewer came in, the president of the Lockton Group, and went over case, example after example about why that will happen. So why wouldn't I do that under this situation? And like he said, most of his clients told him, I'm not going to be first to do this, but I'm not going to be third. And finally, what's going to happen is you're going to have a debate between the chief financial officer and the HR people. I've done it around the table. And finally, the chief financial people win. So tell me why that's not going to happen.
Well, I think, Congressman, one of the things that that assumes is that there is no advantage to a business owner for keeping great employees and tying those employees to a health insurance plan. And what we see right now is a voluntary marketplace where people have entered voluntarily. Your premise is based on the fact that that employer, you in this instance, or someone else, drops all the employer
But if
coverage.
if you're over 200 employees now, which we are, almost all of them provide health insurance coverage right now. And as you see reimbursements, especially in our business, with Medicaid going down and with Medicare, and I hope I have time to get into Medicare, why wouldn't I do that?
Well, I think that the exchanges are particularly being designed for small employers. You, in the instance of having the number of employees that you're talking about, are likely to be banned from initially entering the exchanges because of the
With all due
position
respect,
that you...
they can.
Pardon me?
They can. I mean, I've read this. They absolutely, we can do that if one person goes in there and we decide to drop it. Anyway, that's fine. I'm not going to get an answer. The other question I have is, in Medicare, I'm particularly worried about because healthcare decisions, I believe, Madam Secretary, shouldn't be made here in Washington, D.C. They should be made between patients and their families and their doctors, not by insurance companies and not by the federal government. And my concern is we've just taken $500 billion out of an already underfunded Medicare plan. And your number is 3.3 million people we're adding per year. That's another 35 million people in the next 10 years with $500 billion less dollars. How does that math work?
Well, Congressman, as you probably recognize, the $500 billion is a reduction in the growth rate of Medicare from what's estimated to be about 7.8% to closer to over 6%. So it is not taking money out of the program. It actually is trying to slow down the cost growth without changing any of the guaranteed benefits. And indeed, there are additional guaranteed benefits. I would suggest that the House-passed budget, the House Republican budget, that suggested that vouchers are the appropriate goal for Medicare, and turning over Medicare patients to the private insurance market does nothing but shift enormous cost onto seniors in this country, put an insurance company between them and their doctors.
Madam Secretary, I hate to interrupt. Dr. Rowe, the clock is demanding here. The committee is in recess.